Thank you very much, Gabor, and thank you. I'm very grateful for this opportunity to talk about a topic that actually concerns us all. I would just like to ask one question. How many of you have been confronted with a bifurcation lesion in your practice so far? Any? Probably most of us. And this is true because 1 in 5 of our PCIs will be a PCI of a bifurcation lesion. There are 2 other more statements that I think we can say about bifurcation PCI. The second one is that, as everybody noted at the beginning, the side branch is very important. There is an intrinsic problem, an intrinsic danger that while treating what we are pursuing as the main vessel, we may jeopardize the side branch. That is the second thing that we know. So we really need to be careful about the second vessel. And then the third thing is that the anatomy is very important. It will have an impact on how we treat the patient. So we really need to analyze the anatomy. Now the question is how to do it. And we have actually talked about this in the past few minutes. And actually what I would like to offer is one way to do it is to think about it as a puzzle, as putting the puzzle together. So it's means of reconstructing the picture. Now, the first step in every puzzle, and here you can actually see a puzzle of a big bifurcation being the Eiffel Tower. So the first question that we have when we have a puzzle is the bird's eye perspective. It is the overall perspective of what our picture should be. Now, in bifurcation PCI, this may be called the Medina classification. How many of you have heard of Medina classification? Many? Yeah, most of us. Because this is something that we find very useful for at least 2 reasons. The first reason is it gives us an information about the likelihood of side branch jeopardy or side branch closure. And the way to quantify or to express this jeopardy is what is called the true bifurcation. So if we have a severely diseased side branch, and in addition we do have diseased proximal or distal main branch, we would call this a true bifurcation. The second reason why we may find Medina classification useful is for the purposes of communication. And this is why so many of us know it. It's easy to communicate between ourselves and also in clinical trials what degree of the jeopardy of the side branch there may be if we use one classification that is understandable to most of us. However, I would say that this is only the bird's eye perspective. This is only the overall picture. Now, this is what we may be missing, and these are the pieces of the puzzle that we need to put together. And Gabor and Alessia did it actually fantastically because you more or less mentioned most of these pieces of the puzzle. The question is how to put them together, and the question is to know why are these pieces important. And this is what we are going to do in the next few minutes. So the first piece of the puzzle is what the diameters are. The diameters will tell us how our strategy will be, how we choose our stents, but the diameters may also tell us about the importance of the side branch. If we have a large diameter side branch, it probably will correlate with the importance of the myocardial territory subtended by this side branch. The second point is the plaque distribution. The plaque distribution will tell us how to treat and what to look at while treating the bifurcation, anticipating what will happen after predilatation or stenting. And the third point is bifurcation angle. It's actually important for many reasons. It actually is important for several steps in the bifurcation process as we will have the opportunity to see. So the first piece of the puzzle are the diameters. How many of you have already seen this slide before? So, some. Okay. Because this, I would say like 20 or 30%, but I think this is maybe the cornerstone of understanding the bifurcation anatomy. So when dealing with the bifurcation anatomy, we have the basic problem. We have one stent, which has one stent diameter, but we have 3 diameters of the bifurcation. And these 3 are different, and you see on the left-hand side of the slide, which is in green, the correct mathematical relationship between the 3 diameters of the bifurcation. The proximal main branch equals 2/3 of the sum of the distal main branch and the side branch. So 1 stent diameter versus 3 bifurcation diameters. Now the question is, why is that important? And on the next slide, you basically see why it is important. Now look at this real-life case, and you see the proximal distal main branch diameter and also the side branch. Now the question is, which stent do we put in? According to the proximal diameter to distal diameter of the main vessel, or according to the side branch diameter? Well, what the operators chose to do is to put it actually according to the proximal main branch diameter. And this is what happened. Look carefully what happened. On the left-hand slide, you see the initial, the baseline, and then you see it after 3.5 millimeter stent. So what happened, more specifically, is something which we may call or regard as the carina shift. So we pushed the carina towards the side branch. This may happen if you oversize your stent. And this is why it is important to understand the first piece of the puzzle of the bifurcation anatomy, which is that there are 3 different diameters of a bifurcation. The second piece of the puzzle is plaque length and distribution. And this, on the left-hand side of the slide, depicts how it looks from the inside. This is a pathological finding where actually you should see that the carina is virtually free of the disease. So you know that the plaque distribution is such that it will be on the opposite walls of the bifurcation, not at the level of the carina. This has to do something with shear stress, where you have low shear stress on the opposite walls. Now, what are the consequences of this? Why is this important? And on the next slide, you see the possible consequences. So you see the plaque distribution here, and when you analyze it carefully, you actually can see that the plaque stretches from the proximal, from the distal RCA, which is the proximal main vessel, into the side branch, into the PLA. Now, the reasoning of the operator here was that PDA may be a more important branch. So what happened is that a stent was placed into the PDA. Consequently, the plaque was shifted towards the side branch. And we do have a picture of what may be perceived as perhaps a combined effect of carina, but also the plaque shift. So analyzing plaque distribution as the second piece of the puzzle is very important to anticipate what will happen after stenting or dilating the main branch. The third important piece of the puzzle is the bifurcation angle, and it does have different implications. It has implications for wiring, but also for carina shift, but also for side branch ostial coverage. And as you can see, when you see a narrow bifurcation angle, this will be important for the end of the presentation, but if you see a narrow bifurcation angle, you can of course be happy because your wiring may be easier, but what may happen after the stenting is that it would rather have the propensity to close or to occlude after the main branch stenting. Now, the question is, when we see all these things, all these pieces of the puzzle, is it all? Does it change during the procedure? Well, it's not all, and it does change during the procedure. It's not as easy. So there are some challenges which I have come up with, and I'm sure there are many more. But the first is finding the working view, as has already been said. And what is most often missed, actually, is the side branch ostium. So you basically don't pay sometimes enough attention to it, and you're not really sure. You go into the procedure without the full knowledge of the extent of the disease or of the bifurcation angle. This can complicate matters, as I will show you. The second is that as you proceed with the procedure, the anatomy may change, and this you will see as well. And the third point is something which has been talked about in the previous lecture, and this is intravascular imaging. It does expand our knowledge about the anatomy. It is not a gold standard yet, but in some situation, as for example, ostial LAD plaque, it can help us guide the procedure. It can help us tell us where the plaque ends, how long does it stretch it back into the left main. To the first point, finding the working view. This is just a very common overview of the projections that are common and that are typical for our finding the correct view of our bifurcations. However, there are challenges, as we said, and this is also a patient of ours who came to us with typical chest pain. We did a common coronary angiography with the views that you just saw on the slide before and tried to find the reason for his chest pain. And then we saw nothing. But then after really trying to obtain a good visualization of the side branch ostium, afterwards we were sure, or we thought, that we found the answer. So as you can see on the left-hand side of the slide in green, after finding the working view, you actually detect the side branch ostium severely diseased, which was not seen on the right-hand part of the slide in the first cranial. This was even the right anterior oblique projection with cranial view. and we saw nothing. So it is important, before you indulge yourself into a bifurcation PCI, before you dare to begin with it, it is important to take a step back and really try to analyze all of the points. Here you can also see how the bifurcation angle changes after wiring. So going from a very wide angle to a narrower angle after wiring. And this is a recent case that we had, and several speakers have mentioned it, having in mind that there is a fellows course approaching. You tend to look more closely to your everyday practice. So this is one of the benefits of education that I think is very important. If we talk about what we do, if we try to exchange information about what we do, we are first more transparent, and second, we pay ourselves a closer attention to what we do, because we know that 150 pairs of eyes are going to be looking at us. So let us see what happened. This is the baseline anatomy. Let us put the pieces of the puzzle together. Bifurcation angle. Doesn't look too narrow. Looks rather wide, to me at least. Second thing, plaque distribution. I actually looked at it and I thought, well, a lot of plaque is going into the side branch, so it might be wise to wire both branches and to even contemplate side branch predilatation. Let us see what happened. And the third, before even beginning, I thought, well, I better think about the stent that I'm going to put in it. The proximal main vessel, it's not clear where I'm going to end the stent, and it has a lot of consequences, as the next speaker and my mentor will say. But the stent, the proximal main vessel diameter here, I thought would be important to see that there is another side branch there, so we really need to know which diameter we choose. So what happened is that this was the initial bifurcation, so we say, okay, this is easy. We will put 2 wires and then everything will proceed smoothly. Well, we put the first wire into the LAD and the patient got ST elevation and the chest pain. So then we started to think, well, we should be quick with the side branch wiring, and this is what happened next. Look at the left-hand slide circled in blue. So what do you see here? It's the main vessel predilatation. Is there something missing? Can someone shout what is missing? Wire where? In the side branch. So obviously we did not get to wire the side branch because the patient developed chest pain and we predilated. However, we knew, as we know from the previous slides, that the anatomy can change. The plaque can change, but also the angle of the bifurcation could change. So with the undersized balloon, we predilated. There was good flow afterwards, and the patient was feeling very well. And this is also what happened. The bifurcation angle changed. Now look closer at it. Still there is no side branch wire, but the ostium of the side branch does look differently. It looks like the wiring will be much easier now. And look at it here, once again magnified. This is our baseline position. And this is what happened after main vessel predilatation. We ended up with a 2-stent strategy, and it was a very nice result. Anatomy guide strategy, that is the conclusion. So we need to understand the anatomy in order to be able to develop a functioning and good strategy. These are the pieces of the puzzle: diameters, plaque length and distribution, and the bifurcation angle with a focus on side branch ostium. Then we develop the strategy, and we have to be ready not only to assess the anatomy, but also to adapt to the changes that may come along as we go step by step in the bifurcation PCI. With the ultimate goal, actually, of coming back to our initial slide, the puzzle, we need to reconstruct the anatomy. One of our main goals is actually, by treating the bifurcation, to try to stay within what the Mother Nature gives us, to reconstruct the initial anatomy. Thank you very much.
Thank you. Any questions right here, right now, at this moment?
Could you consider the wiring of the side branch first? In this case, you wired the main branch and the predilated it.
That's a good question. Well, the problem was that the patient history was such that the patient had actually NSTEMI. So he was referred to our institution after 2 or 3 days of the chest pain onset, and we thought that this plaque may be an unstable plaque. So after wiring the LAD, he quickly developed symptoms, which is why we chose to wire first the LAD to secure the largest myocardial territory.
And I think one more important point to this question, indeed, we like to say that wire first, which requires more manipulation, because this is how you can avoid wire twisting. But in this anatomy, if you look, the major tortuosity comes in the LAD. So if you place a wire in the LAD, it straightens the LAD, it removes a lot of complications, so I mean a lot of difficulty from wiring the side branch, as it happened here. So I would say in this case, it can be wise to wire the LED first. It makes your job for the diagonal much easier.
But it is, I think it's a good example of flexible thinking. So basically, of course, if this was a stable patient, and if it was calcified, for example, and as I was told after the procedure, I could not always count on the side branch being patent after main branch pre-dilatation. So in a more stable situation, this may have been an option of securing the side branch first.
Other question?
If I'm doing a bifurcation standing, I will always keep side branch interest much more.
You would always protect the side branch, you say? Yeah, it's definitely a consideration. Indeed, it's the safest way to protect the side branch always, but indeed there are clinical scenarios when you are obliged to move fast on.
Another question. Yeah.
Okay, thank you very much to your presentation. It is necessary to use additional images like OCT in bifurcations with previously stents in order to understand the anatomy?
Yeah, well, it is a controversial topic. So I would just say my personal experience and view with that, which is not supported by any studies. So as I said, one example that I have where imaging at least helped me understand the anatomy is ostium of the LAD. So if you have a plaque at the ostium of LAD, doing imaging in such kind of patients, you actually learn that most often the plaque extends into the left main. So if you would plan a PCI of putting a stent and ending the stent before the left main, you would know, or you should know, and this is the information that you get from the imaging, that there is still plaque you're actually ending with your proximal part of the stent in the plaque that extends into the left main. So this is one example where imaging could really help you understand the anatomy, the plaque distribution part of it.
Dan, we have one question here.
I think it's a rather difficult question, but perhaps could we see the images of the LAD diagonal PCI that you just did? I think one of the points that you pointed out quite importantly was that, of course, in order to want to protect the side branch, we at least need to know something about the territory and the importance. But I think I saw another image in which that diagonal actually was approximately the size of the catheter, perhaps even smaller. And I was wondering why you chose for a two-stent strategy in the first place, and making the question a bit broader. Are there any guides for us to understand what an important side branch really is? A certain diameter or a certain length of disease at the ostium?
Thank you very much. I will confine my answer to the realm of bifurcation anatomy, because next speakers will talk about strategy and the difference between provisional and two-stent strategy. Concerning the anatomy, if you see all of these points that we mentioned, the conclusion you can draw is that this bifurcation is definitely 1-1-1. And you can also say that there is high likelihood that the side branch will close after placing the stent into the main vessel. This is the anatomical information that you have. To go beyond that would require, I think, an experienced approach. And what is considered to be the gold standard approach at the moment is the provisional approach. So you're always playing on the sure side, on the safe side. If you say, okay, I analyze the anatomy, I know that the likelihood is high, and I know that the data, the literature supports the provisional approach. So what I will do, I will place the stent into the main vessel, knowing that there is high likelihood that I will need a second stent, which is what we did. We did a top stenting at the end of the day.
Okay, thank you,
I
Dan.
hope this was enough.
Since the next talk will be about the PCI technique anyhow, I would like to go on in a way that everything that we have just learned from you, let's try to use it to analyze the cases of Alessia together. So if you can show the flip chart, I put everything here, what they have mentioned, that these are what we need to understand when we look at the angiogram. So, can you just project the flip chart? Very good, so it's there. So, when we want to decide about which technique to choose, how to perform PCI, and let's say we want to understand the talk of Goran in the next talk, we need to understand these parameters for the cases what we are going to treat. So this is the first case what we discussed, the LAD diagonal bifurcation. So I would like to ask someone or all of you to help me to go through all this criterion. How would you interpret this case according to these parameters? Can I ask you?
Medina, this is Medina. At the left picture, I can say it's 001, but at the left one, yeah, it's also 001 maybe. Bifurcation.
Okay, then
Somebody
let's
else
make a
would
poll
like
because
to-
let's make a poll because there are some discussions.
Yeah.
So who says? Let's start point by point. Proximal main branch, is it diseased?
Yes.
Yes, it was quite loud. Yes. Distal main branch diseased?
Yes.
Very loud. Side branch diseased? Okay, so let's say the bird view, or how do you call it? It says it's all the three branches are involved. Okay, but then let's go on. Reference diameters. What do we have? Yeah, when we want to talk about reference diameter, we are selecting our main branch stent, and we have to define first the reference diameter for the distal main branch. So what would you say?
Gabor, sorry.
Looks 3.5.
3.5, 275, 3, lot of discussion. Okay. Side branch diameter. Who says it's smaller than 3? Smaller than 3, everyone. Smaller than 275? Fewer? It's a 6 French diagnostic catheter.
You mean in diameter?
It's
2
in diameter,
millimeter.
the 6 French is 2 millimeter.
So the lumen is 2 millimeters.
The catheter
No, it's
is 2 millimeters.
It's 2 millimeter, the catheter. Okay, so now considering this one, what just mentioned by Professor Marco, the catheter is 2 millimeters. So what is the size of the side branch? Who says 2.5? 2.5. Who says bigger? Okay, but you think that you can perfectly evaluate this or answer this question based on this NGO? Someone hesitated. I was. Okay. So, but let's say in these projections, we at least see the distal, the proximal reference diameter, and the main branch. Angulation, Diane just mentioned if it's small angulation, it will be favorable for your procedure, but worse for the side branch patency. Is it smaller than 70%, 70 grade? Smaller, so it's a small angulation. Okay, and the plaque distribution, we discussed it when we were talking about Medina. Just to summarize, based on these two images, at least everyone was more or less confident to say something about the involvement of the three branches, so proximal, distal, side branch, about diameter and about the angulation.
About side branch important,
Yeah.
What does it mean, important?
Exactly, this is the other thing what...
You're speaking about diameter.
Yeah, this is the other what Diane just mentioned. We have to decide whether the side branch is important. So what is important? Well, how do you define that the side branch is important? Define, you say diameter and territory. Which diameter is important for you? 2.5. More than 2. What is the territory which is important for you? It's covering large area. I would say it's very hazy definitions. I would say important what you don't want to lose.
Yeah, exactly. But just a second. We all talk about. Thanks. We all talk about diameter, but there was one voice here who said, "Well, if it's long, it's also important." And I think that's an important information. I actually read it not many years ago that it's not only the diameter, but it's also the length of the side branch. So if the side branch is like 2 millimeters, as for example someone said, but it's very long, is go to the apex, that's also very important. So it may be also clinically important. We also had one case in a tiny lady with a very tiny 1.5 millimeters diagonal. We lost it. She developed chest pain and ST elevation on the monitor ECG. So we had to go back and post-dilate and actually reopen the side branch. So it's not only the diameter of the vessel, it's also the length of the vessel.
Exactly. So I think, just as you said, you have to have in mind before you start with your procedure, if you lose, or if the patient loses the side branch, does it matter? If you say yes, then it's an important side branch. If you say you will not care about losing this side branch, then it's not a bifurcation lesion.
Your comment is important comment. If the side branch is occluded at the end of the procedure, what will be the consequence for the patient? For example, you can have a small side branch on distal right or marginal right, but the risk of occlusion is mitral dysfunction, for example. This happens. You know? So give me a conclusion. So it's not only the diameter, it's not only the length, but what could be the consequence, myocardial consequence of the occlusion of this side branch.
Thank you. So, then just with this aspect, looking at this case, who thinks that we can lose this diagonal? No one. I'm happy to hear that. Let's go to the second case. Who thinks that we can lose this circ? No one? So we can consider it's real bifurcation lesion. And finally, the right, I think, again, no question. So we can say it's important if the patient loses this branch, whatever the diameter, it will definitely matter. So